Well, guys, listen, it's always a pleasure to speak, especially to all my friends in India. So I hope this is valuable, even though, as I think was stated in some of the promotional material, these are extremely rare hernias. Vedra is a great panelist for this. She has published some on this area, and I'll talk about that. Conrad as well has posted at least one really amazing robot case on the International Hernia Collaboration about the topic. I have disclosures, but they will have no relevance in what we're talking about today. So really three goals for the presentation today, and then we'll answer some questions. I'd like to describe kind of the radiographic appearance of what thoracoabdominal hernias look like. As you guys know, with a lot of my radiology talks, I believe that making a good diagnosis allows you to make a good plan. And so if you understand what you're tackling before you head to the operating room, I think you're going to get the best outcome. We'll talk a little bit about the steps of the operative repair. Again, there's not a lot out there in the literature, so I'll show you a little bit about what Vedra and her group put together. I'll talk a little about how we have done our series here, and we'll talk about some of the outcomes from those repairs that are hopefully optimized based on the first two steps. I'm going to show you a video here. This is a patient who is a 65-year-old who presented to an outside hospital after a bout of forceful coughing. He was diagnosed with a traumatic injury to the chest wall. He was taken to the operating room. He underwent a thoracotomy, posterior lateral thoracotomy on the left for repair. And he woke up still with a bulge, having had a mesh-based repair, and was ultimately referred to a local abdominal hernia surgeon for evaluation. And they noted some things on the CT scan that I'm showing here that made them concerned that this was not just a flank hernia. And they actually referred him to me because of a previous case that I had presented on the International Hernia Collaboration. This guy is from the next state over. So this is the hernia that we're looking at here on the left-hand side. And there's obviously a lot of complex things going on, and we'll break the scan down here in a little bit. I'm going to show you some coronals here now as well about what this looks like in coronal views, just to get an understanding of, again, anatomic location and complexity, because when this man stands up and you look at this for all the world is, a flank hernia, all right? And I think that this was initially how he was billed to the outside surgeon. It's how it came in my medical record request as well for booking. Patient with flank hernia. But there's obviously a lot more going on than just a flank hernia. So let's talk about thoracoabdominal hernias. So these are hernias that originate in the chest, the bony chest wall, and extend into the abdominal wall. And they are obviously quite rare in their presentation. There's really two variants to this. The first one I've already described. This is sort of the spontaneous or the primary variant. And these are associated with chest wall trauma, like a motor vehicle accident or a deceleration injury, coughing, and are usually associated with obesity. The majority of the patients described are obese. There's a second, which is basically an incisional hernia variant. And these are patients who have had a thoracic operation where the anterior most extent of the thoracic incision came onto the abdominal wall, myofascial planes, or a retroperitoneal operation as well, like a retroperitoneal approach to the kidney that happens to go in between the posterior thoracic rib space. Now, notably, there's not a lot of good language, at least in US coding, to describe these things. And the European Hernia Society classification system really does not include anything about hernias that extend onto the chest wall. Just as a refresher, the EHS zones are midline zones, but these all by the definition start below the level of the xiphoid and the costal margin. So the M1 and the M2 zones here, while we're showing you a 3-centimeter distance below the xiphoid, they're really bounded by the bony and cartilaginous landmarks of the chest wall. Similarly, for the lateral zone hernias, L1 and L4, which officially abut the inferior and posterior portions of the bony chest wall, are really still just myofascial planes. There's no extent onto the chest wall. Now, the good part about the EHS measurement system for ventral hernias is that when we think about the length and the width of a hernia or hernias, we know that you take the maximum width between defects and the maximum height. And so this portion of the EHS classification scheme can still be used to describe these because you're really just measuring the length and the width. It's really those midline and lateral zones that ultimately fail in the description. So what's out there in the literature? Well, first off, there's really no large studies describing these hernia characteristics or repair to date. Vedra's paper, which I'll talk about, is the largest one. But really, you know, I think it's was 16 patients at the end of the day. And so when we think about the hundreds and hundreds of patients that are described in other series, you know, these numbers kind of pale in comparison because of the rarity. Prior to that report by Vedra and Alfie Carbonell, what was out there in the literature was mostly just sporadic case reports that focused on the presentation of the patient and then the operative repair, you know, what steps were taken and post-operative outcomes. There's one review from the literature of 2017, which was 15 cases that it took them from 1977 to 2017 to find 15 cases in the literature of what they were describing as thoracoabdominal hernias. This slide, maybe it doesn't project as well as I was hoping it would, but this is the table from that presentation. What I want to point out is I'll highlight these two here. These are two cases from within that series that actually describe the presence of a concomitant abdominal wall hernia. So what this report was actually describing were bony chest wall defects, which had abdominal content and or diaphragm injuries associated with them. Only in two of the patients in this series was there actually an abdominal component as well. So this series is really not thoracoabdominal hernias, it's mostly chest wall hernias with abdominal content. The series by Vedra out of Carolinas, coupled with Alfie Carbonell and Will Cobb's group from South Carolina, had 16 patients, and they were focused exclusively on primary hernias. So ones related to cough or other spontaneous conditions. And interestingly enough, they had a very heavily male predominance of 15 patients, with only one of them being female. In looking at the etiology of primary defects, 15 of them were after forceful coughing. One of them was after strenuous physical activity. 12 of them had had an acute respiratory illness. 2 of them were active smokers, but 10 of the patients in the series had a history of smoking in the past, 4 of them with concomitant COPD. So again, we're beginning to see some of the risk factors that look very much like what the risk factors for ventral and incisional hernias look like as well, albeit with maybe a slightly difference in the male to female ratio of predominance. Let's talk about the radiographic assessment of these hernias. Cross-sectional imaging obviously has the best role, just like it does for ventral hernias. We looked at all of the patients who presented to our institution from 2014 to 2019 who had these hernias and pulled up the cross-sectional imaging findings, and then we correlated those with the operative notes so that we could kind of look retrospectively at what we were seeing on the CT scan. If you've heard me give a CT scan talk before, you know, my biggest point to hernia surgeons is that the radiographic reports for these hernias are often wrong, and this is especially true with these thoracoabdominal hernias. And so it's really on the surgeon to look at the images and understand what's there. And to be perfectly frank, because I don't recall ever fixing any of these when I was a fellow, my understanding of what I was looking at on the CT scan was probably pretty poor back in 2014. But now that I've seen some of these, what I'm going to show you is some presentations that my lab fellow did in 2019 at EHS, which was 5 patients. I've actually done 3 more since that time. I think that it's the understanding of the radiographic assessment that lets you have insight into how you're going to do the repair. So what we looked at were the defect dimensions like any other report and what the hernia contained. But some things that were sort of notable were what was the level, what was the thoracic interspace where these were herniating? Were there bony or cartilaginous injuries, and could we describe those? And we also looked at the degree of rib displacement associated with the defects. So let's look at some of these and our results. All of the hernias in our series occurred below the 9th rib, and they were all associated with a complete disruption of the intercostal muscle. So I want to show you these pictures in a little more detail, so let's bring this up here. So we've labeled some of the ribs here so that they're a little bit easier to see. What I want to point out here is the intercostal muscle disruption here. This is a very subtle injury at this level. What you're seeing, though, is an intact, this is the rectus, this is the transversus that will eventually insert on the diaphragm. Here is the internal oblique inserting on the rib cage, and here is the external oblique that goes up onto the chest wall and ultimately higher up will kind of interdigitate with the latissimus. So this is the abdominal portion of this. Here we see the 9th rib and we see cartilaginous insertion, but here we see a defect. And again, extremely subtle, but what you're actually looking at is a tear in the intercostal muscle right here. Very small, very subtle defect. Now these are not always that subtle. Here we see a much larger defect. The 9th rib and the 10th rib here are displaced, and there's content going between them. And for that to happen, the intercostal muscle between these ribs has to have been torn. Now, on some of these, you can actually identify where the muscle belly is located. This particular cut doesn't let you do that, but you'll oftentimes see a small balled up portion of intercostal muscle adjacent to the bottom of one rib or adjacent to the top of the lower rib. And so similar to the way we see muscles that retract, lateral muscles that retract in an abdominal hernia, you'll see intercostal muscles retract and be attached to the ribs above or below the defect. In all of the patients in our series, the overlying musculature, either the external oblique on the abdominal portion and the lower portion of the chest wall, or the latissimus dorsi as we went higher up onto the bony chest wall, were intact. And what that means is, in the patients we were looking at, these were partial thickness or more or less intraparietal hernias. So again, let's take a look at that in a little more detail. Here we see a left-sided defect, rectus abdominis muscle, transversus, internal oblique, external oblique. Here is the external oblique intact over the entirety of this defect. You can see, obviously, liver herniating through this defect. What that means is that somewhere between here and the posterior portion of the rib that we're seeing here, there is disruption of the internal oblique and the transversus. And we'll talk about it in a minute, depending on the exact location where you are, potentially the diaphragm, because the diaphragm inserts somewhere in this location on most patients, but intact external oblique over the top. Similar patient, left-sided defect, intact external oblique, disrupted intercostal and oblique muscles as well. Two of our patients had diaphragm involvement. And again, this is the area where I think learning to look at these films is very helpful, because the very first patient that I did, which I'll actually show you a little later on in the operative photos, I did not appreciate the diaphragm involvement. I think in the patient that Conrad presented on the International Hernia Collaboration as well, I think that was one of the things that was missed in the review of the imaging. So, you know, I think it's easy to get burned in the understanding that there's a diaphragm injury there. And, you know, I think that's on us to review, but I also think that obviously looking for diaphragm injuries is very challenging. We know that in a traumatic setting, injuries to the diaphragm can be very subtle and can be very easily missed. And I think that's true here, even when you have the ability to look, because it's not a, not an urgent thing. These are generally being repaired, at least in my experience, electively. But again, two of our patients had diaphragm injuries. Let's take a look at those. Lateral defect here. The tip-off to this one having a diaphragm injury is going to be the level at which this is herniated, okay? So you're gonna have to count the rib interspaces and recognize that this is pretty high. This is occurring just below the 9th rib. It's posterior and it's on the right. And so the diaphragm is involved. And so identifying where is the diaphragm, here's the right crural pillar, here's the right dome of the diaphragm, here's the insertion of the diaphragm. It's kind of lost. You don't see a clear muscle plane here. And again, this is not obvious. You can't say 100% there is, but you have to be suspicious that there is based off of this CT scan. This patient is a little bit more obvious because you can see the diaphragm here anteriorly coming down and inserting on the rib cage, but then you see content herniating out. And so there's a diaphragm injury here, but notably on this patient, the content and the diaphragm defect all herniate through the bony chest wall. In this particular case, there's not content going up into the pleural cavity. And so these are special types of diaphragm injuries in some patients. We identified transversus abdominis disruption in all of the hernias. And in most of them, in 5 of our 6 patients, there was disruption of the internal oblique as well. So what that means is that when the transversus and the diaphragm get disrupted, or when the transversus and the intercostal get disrupted, most of the time the internal oblique also gets torn, but not 100% of the time. Again, just speaks to the fact that these are partial thickness defects. Here's a patient who has actually an intact, a disrupted internal oblique and transversus. Remember, the internal oblique will insert on the rib cage here, so that's gone. External oblique is intact over the top. Same thing on this slide here. The majority of our patients had substantial caudal or inferior displacement of rib interspaces. So this is a more subtle defect here. But if, because people are symmetrical and bilateral injuries in these particular cases are rare, although they have been reported, what you have is you can identify what is the normal interspace on a patient. So you can look at the contralateral side and make an assessment about the degree of displacement simply by measuring the distance between the ribs. I don't know specifically what to tell you to make of the degree of displacement, other than as the displacement gets greater and you have a greater gap between ribs, oftentimes those lower ribs are essentially floating sections, floating rib segments. And in those particular circumstances, you might give consideration to repairing the bony chest wall with plating or wires, as we'll describe in a little bit. So that patient, which had 12 millimeters of distance between the ribs, is obviously a lot different than this person that has 9 centimeters of inferior displacement between the ribs. So very different size defects here with potential different implications for how we might do the repair. 5 of our patients had abdominal viscera. One of our patients, this extremely subtle defect that I'm showing you here. So obviously this one's got a spleen and some colon going out into it, so abdominal content. You can see the spleen being rotated there. This patient has a very subtle defect here. This was actually a traumatic defect from a deceleration injury. This patient also, you may note, has a midline incisional hernia here from the laparotomy they got from their trauma, but has this defect in the intercostals with some retroperitoneal fat, some pericolonic fat poking out here. In our series, most of the patients also had bony injuries or cartilaginous injuries associated with the defect. So some of these can be extremely subtle. So this is a patient who has a small bony island right here where the transversus and the internal oblique have been disinserted essentially from the 11th rib. So there's a small section of that 11th rib, the tip of it essentially right here. You can see fractures in cartilage. You can see disrupted cartilage. You can see the normal insertion and the abnormal insertion. You can see portions of ribs that are kind of free-floating lower down as well. So in our series, the average defect size was about 10 centimeters in width, 10 centimeters in width, very oval-shaped defects in general. The boundaries, again, all of ours were below the 9th rib, but most of them, 50%, were below the 9th rib. And and then 2 below the 11th rib. Mean displacement of the ribs in our series was 6.8 centimeters. So let's go back then and look at that first presentation, the first patient that I showed you earlier. And let's spend a second here and let's look at what this guy's defect actually looks like. And let's talk about the things that we just talked about, okay? So we're looking at a left-sided abdominal and thoracoabdominal defect here. The things that I see when I look at this, I'm gonna start by looking for where is this defect coming out? And I'm not gonna bore you by counting, but we can count the interspaces here, and this actually comes out below the 9th rib. Now, one of the things I'll tell you is this patient has already had a posterior repair, and he had a primary suture repair of the muscular defect, and then he had an onlay piece of mesh with lightweight polypropylene, which is very challenging to see on this imaging study, but we could feel it in the operating room. Let's look at the diaphragm first, and let's see if the diaphragm is intact here. So here's the right-sided diaphragm here. If we follow the diaphragm around, we can see that the diaphragm, in this particular case, is disrupted. So there's a diaphragm disruption here from its insertion point on the 11th rib. But none of that content actually goes up into the chest. It actually all comes out through the bony defect in the abdominal wall, in the chest wall, and comes out lateral. We can see some colon here. And as I described earlier, the colon appears to be bounded by intact external oblique aponeurosis. So again, a partial thickness defect here. As we come down lower, that diaphragm defect continues inferior as a defect in the transversus. So here's the rectus, here's the external oblique. This complex is going to be the internal oblique and the transversus, and they have a defect in them from their insertion point on the rib, on and underneath the rib, with, at this point, small bowel coming out, being trapped underneath the external oblique. So we're seeing a lot of the characteristic defects. If you look very subtly, you can get a sense of what the downward displacement of the ribs is. Let me go ahead to the coronal section here. Here's the coronal section, and we can see the downward displacement of the rib, right? Here's the displacement between 2 ribs. And what that should actually look like is 1, 2, 3. We're missing a rib here. If we look down a little farther, there'll be another rib here. This patient actually had some upward displacement of rib spaces as well. We didn't really characterize that in our series, but it is sometimes seen. What I'm not showing you on this is what this guy's initial CT scan looked like. He had a CT scan that also showed a splenic injury. There was a small perisplenic hematoma. And so recognizing that this was from an acute traumatic event and he had surgery, I think being prepared for splenic adhesions is obviously something you want to consider. Finally, on this guy, there are some rib fractures. If you look very carefully, he has some very subtle rib fractures, which at this point were healed and stable, and his bony rib cage was for the most okay. There was one other thing I wanted to show you on this, but I can't recall what it was right now. So in the interest of time, I'll skip it. And if it comes to me, I'll come back to it. So let's now talk about, oh, I know what it was. It's denervation, okay? On his initial CT scan, he didn't have any denervation because it was an acute injury. But if you look at now, this is months after his initial injury, at the right-sided rectus abdominis and the left-sided rectus abdominis here, as a consequence of his posterior lateral thoracotomy and probably the traumatic events of the injury with the disruption of intercostal nerves, he's got a denervation injury of the rectus here. And so no matter what we do on this side, he's going to have a long-term denervation injury, and that expectation needs to be talked about with the patient. So how do we repair them? Well, there's obviously a lot of things going on here that need to be considered. So first off, there is a myofascial defect of the chest wall, right? That is disruption of the intercostal muscles that needs to be considered. There are bone and cartilaginous issues that includes active or unstable rib fractures that may need to be plated for chest wall stability. And then there are increases in the interspace between the ribs that may require wiring to reduce that defect. There's an abdominal wall defect, and that's maybe the only part of this that most of us deal with on a regular basis because, again, most of our hernias are abdominal wall myofascial defects. So the disruption of the transversus and the internal oblique are the things that are the easiest part here to fix. There may be a concomitant diaphragm defect, and so if you don't do a lot of diaphragm hernias, you have to be prepared to deal with that. And again, as I said earlier, you may or may not know, this is a photo from Vedra's series, and this diaphragm defect is a little more obvious because you can see colon going upward into the chest and actually into the pleural cavity. So when they're obvious, they're obvious. When they're subtle, they may still be there, and you just need to be prepared for that. And as I said earlier, the potential denervation injury should at least be identified now and discussed with the patient in terms of expectations for the repair. What else do we consider when we do these? Well, patient positioning for me is generally a flank. It may be a true flank, especially if these are far posterior. It may be kind of a lazy lateral position if I know that I need to go farther onto the abdominal wall, depending on the extent that this goes and its proximity to the linea semilunaris. Postoperative pain management for these can be challenging, especially if you're wiring ribs and plating ribs. Our usual postoperative analgesia, like an epidural, covers both sides. You don't really need that coverage. I do a lot of tap blocks for my ventral hernias. You can't get that coverage here with a tap block. And so I've been using paraspinal catheters that are placed at a thoracic level, and they seem to work very well for these. You can consider using a chest tube. I generally don't, because there is not an acute injury to the pleural cavity. I think Conrad has used them in his series, but if I recall, I think he pulled that very early in the postoperative period. Nothing wrong with using it. If there's a diaphragm injury and you're looking at the lung, though, certainly. I think that if you're not comfortable working in the thoracic cavity, taking down pulmonary adhesions, plating ribs, you may want to have your thoracic or chest wall specialists available to help out. And I certainly don't have any problems calling them if I need assistance. We looked at our repairs in a retrospective review. Again, this was stuff that my lab resident, David Morrell, presented last year in 2019 at EHS. And we'll need to update this for the additional repairs that we did. We looked at, again, all of our thoracoabdominal patients and described some statistics about what we did. So older patients, mean age of 65, we had a 60% male predominance. Now, we included both primary hernias here as well as some incisional hernias. And actually, as I think about this now and I think about the data that Vedra had, our female patients were the ones who had the incisional hernias. Most of our male patients were ones who had traumatic ones. So that kind of jives with what she presented in terms of the male predominance in the primary hernias. The BMI of these folks, again, was obese. 31 was the average. And most of these were all clean cases. Most of them were only grade 2 modified ventral hernia working group grade. The defect length, again, 5 patients, 8 centimeter defect by 5 with an area of 120 square centimeters. Some of them were recurrent, having had, most of them were onlay repairs that had previously been done. One was an onlay actually with vicryl mesh, which for the life of me, I don't quite understand. We talked about the musculature disruption in terms of transversus, internal and external oblique. Again, the external oblique being intact over top of all of these. We utilized the EHS classification just to describe the abdominal extent of these. Notably, these were really in the M1 and M2 zones. There were really none lower down. Lateral component, including L1 zone and some in the L4 zone and some in both. We used intermediate weight polypropylene. This is a typo in the slide. We also used heavyweight polypropylene in one patient. All of our meshes were placed in a preperitoneal or sublay space. The mean mesh area there, 676 square centimeters. I didn't use a lot of fixation in these. Most of them were just fixated with a fibrin sealant. Some had some percutaneous sutures as well. Only one of them really required a TAR, and that was not specifically a TAR to allow medialization of tissue. It was simply a TAR to allow us to jump planes to have an intact sublay space. Some of these were smaller. The epidural patient was the one that had a midline defect associated with it, so that was a midline approach, and then interscalene or paraspinal blocks also used. I'm going to show you a patient here, and then we'll go through some of the operative steps. This is a patient that I showed earlier. This is a traumatic coughing injury. I think I went over these images earlier. The only other thing that I'll point out in this image is when I first met this patient, her BMI was in the 40s, the high 40s actually. And so you may have noticed it went by kind of subtly there, but she's had a sleeve gastrectomy here. So this is a patient who we ran through our bariatric program, got her a sleeve. She lost a substantial amount of weight, which made her symptoms from the hernia a lot less, and honestly made the repair a lot easier. Repairing a BMI of 35 was a lot easier than 45. So all of my approach has been open. I don't have a lot of experience doing these robotically or minimally invasively. This is our open approach. You know, you look at this picture and it's very easy to look at this and say, got it, this is a subcostal incision. I think the thing to realize is that it's not. You know, this is the 9th rib here. This is the defect we're talking about fixing. There's a gap right here, and the 10th rib is down here, 11th, and then 12th all the way in the back. So you can see this defect, and you can see the medial most extent of this onto the myofascial planes of the abdominal wall. This was the very first patient that I did. I did not appreciate the extent of the diaphragm injury here. And so I wasn't super surprised, but I was a little bummed when I opened. And the very first thing that I saw was the patient's lung. This is the 9th rib here. Here's the lung. And this is the diaphragm. We're looking at the pleural surface of the diaphragm. And so at the end of the day, this needs to be lifted up and put back into position. So the first step from my end of the repair is just kind of identifying what portions of the repair are going to be usable, and then honestly, what is what. You can see this is the intercostal hanging off of the rib. So I told you the intercostal muscles kind of get bunched up here. This is some of the lower portions of the intercostals, and transversus and internal oblique are in here as this is the anterior portion of the and the medial portion of the dissection. What I'm not showing you here all that well is that the external oblique being intact over the top of this, you actually have to incise the bulging, kind of redundant external oblique over the top of this. So here's the external oblique bulging over the top that we will eventually plicate as the outermost portion of our repair. So the repair starts by creating a sublay plane. We're going to lift the diaphragm up and simply jump into a preperitoneal or pretransversalis plane. And you know, in that regard, these repairs are very much like doing a flank repair. You're simply doing a wide retroperitoneal dissection. And so here is what that dissection looks like. We're now retracting the diaphragm upwards. The diaphragm is up. We've created a large preperitoneal pocket, so the peritoneum is down over the spleen here. And what we're showing you looking up is actually some of the tendinous insertion of the diaphragm superiorly. So we've dissected superior enough that we're seeing the tendinous central portion of the diaphragm here. We'll extend that dissection posterior, we dissected anterior, and we dissected inferior. A very large preperitoneal pocket is created, and we're going to fill that pocket with mesh. In this particular case, you can see we're using a heavyweight polypropylene mesh, and you can also see that in the portions where it is safe to bring out full thickness transfascial sutures, that being anterior, just off the costal margin, superiorly and inferiorly below the rib spaces that are below this, we place those sutures. Now, in this particular case, I did not do any plating, wiring of the ribs. We simply used the heavyweight mesh to span that gap. The next step of the repair is to reinsert the diaphragm. So we're going to tie those sutures down. What we're going to then do is take the diaphragm, which was lifted up, and we're going to basically reinsert that diaphragm on the lower rib space, and that's what you're seeing right here. The diaphragm has been reinserted. I then like to close in as many layers as possible. So the next layer of closure is essentially a closure of the intercostal muscles back together. And as you move anteriorly onto the chest wall, that's a closure of the transversus abdominis and the internal oblique. So Intercostals get closed here. Transversus and internal oblique get closed moving anteriorly. That's the diaphragm, and this is the intercostals. And then what you do is take that bulgy external oblique. You can either transect it and remove it, or you can simply imbricate and plicate it over the top. You can see, like I do with a lot of my big sublay repairs, I've left a drain in the retromuscular pocket around the mesh. So this is the same patient. This is her 30-day CT scan following the repair. Radiology kind enough to point out a rib fracture there. But you can see that even though we haven't closed the chest wall, all of our abdominal contents are back where they belong. You can see our suture lines there where the closure was actually located. This lady does have some very subtle denervation injuries. She's now actually like a year, she's like 2.5 years out now, doing pretty well. Some pictures from a chapter that Vedra wrote for a textbook that Jeff Blatnick and Sal Dosimo and I are editing called the Textbook of Hernia Radiology, which should be out in 2021, showing, you know, plating of the ribs. Again, if you do bony fixation in the pelvis, if you're comfortable doing bone fixation, you can learn how to do rib plating. It's not super challenging, but you do need to know some of the basic principles. You can plate the ribs. That will help you stabilize fractures that may be present. And then, as you can see in the second image here, you can then wire those ribs together to provide stability between the rib interspaces. This is a similar figure from the group series that Alfie Carbonell and Vedra put together as well, showing those similar principles: rib fixation for the bony fractures, and then rib wiring to reduce the defect size that is present. In their series, they had a length of stay of 5.7 days overall, 19% surgical site occurrence rate. One was a simple seroma, no big deal. One was an MRSA surgical site occurrence infection that required multiple surgical drainage procedures. You know, obviously when we're doing hernias and we have surgical site infections and we have mesh infections, that's a challenge. This obviously becomes substantially more challenging when it may involve the pleural cavity. It's more challenging when it involves metal hardware that simply cannot clear an infection. And so obviously that's, you know, we all worry about MRSA, but that's no joke. That's a big problem. And they had one hematoma requiring an evacuation. Again, if you're going to plate ribs, you know, the risk of bleeding obviously goes up a little bit as well. So just things to keep in mind. In their series, 7 of the 16 patients required at least one reintervention. 2 of them were for recurrences. You know, I think this is a very honest statement to make. One of them was simply for a missed abdominal component of the hernia. You know, that's the same thing that happened in the patient that I started this talk with. He had an injury. He was taken to the operating room. He had a repair, but the medial most portion of that extended onto the abdominal wall was missed. And I think that that understanding that these entities exist is probably one of the most important things that could be noted in that paper. You know, these are expert hernia surgeons that are showing you that these patients have problems and injuries can be missed. Our series, which was obviously a lot smaller, had a shorter length of stay. And that may be because we were, you know, this is, some of their data went back a little bit longer. We obviously are much better at doing enhanced recovery protocols. And so that may be part of it. And I think the paraspinal block use may be part of it as well. Hard to say. We didn't have any readmissions or reoperations. To date, I haven't had a surgical site infection yet. It's bound to happen at some point. And we didn't have any recurrences radiographically or clinically. I'll show you some postoperative imaging. Again, this is that patient that I showed you the repair steps on. You know, when you compare the pre and the post-op imaging here, you know, there are substantial differences in kind of how the abdominal and chest wall looks, but there are some persistent things you'll note. There's obviously still, in this patient, a very large gap here between these ribs. And so without wiring those back together, there will be persistent deficits that are noticeable. She does not have any symptoms from this, but obviously on the CT scan, there's a problem. So I'll start with some concluding slides here. Number one, we need a good classification scheme for how to talk about these things. I think there's, you know, maybe 2 options, although things we can talk about. utilizing the EHS classification for medial and lateral hernias, but allowing you to add a T to note if there's a thoracic component up onto the bony chest wall, or adding a D to the classification to note a diaphragm component. That would be helpful. I think option 2 would be just a standalone classification where you're either describing a thoracic hernia that includes abdominal involvement or an abdominal hernia that includes some thoracic involvement. So just some things that I think we as hernia surgeons need to talk about. For the diagnosis, I'll simply reiterate that these are partial thickness defects that involve disruption of the intercostals and the transversus, and very commonly the internal oblique, with inferior displacement of ribs containing hernia content. Osseous and cartilaginous disruptions occur unless it's a floating rib like the 11th or the 12th rib where they're not attached to anything. And solid organ, retroperitoneal, colon are the most common contents. Repair mandates a proper diagnosis ahead of time to repair all of the disrupted elements. If you miss something, you're going to have a recurrence that's really not a recurrence, just a missed injury. I personally favor defect closure with reinforcement by wide overlapping sublay mesh. I think, again, the sublay reinforcement just makes the most sense here. I don't fixate the ribs, although I think there's good data to support doing it. I don't necessarily use suture fixation, although again, I think there's good data to support doing it, but I don't always do it. Challenging hernias, complications, reoperations appear, I think, more frequent in this unique subpopulation of complex hernia patients, and you need to be prepared to manage those. With that, I'll stop. I think that gives us maybe 15 minutes or so for panel discussion and questions. Thanks, guys.
Thank you, Eric. I think it was a very, very crisp talk, and most of us here are actually at loss, and I think you have really clarified a few things. I would ask Dr. Ramana to introduce our very eminent panel. Dr. Ramana?
Yeah. So thanks, Eric. Very, very interesting topic for many of us. So we have 4 panelists today. I'm sorry I couldn't introduce you earlier because Eric's slide came up on my screen. So we have Vedra, who has been referenced by Eric several times in his talk. So Vedra is a surgeon who is working in Charlotte, and she has a large number of studies to her credit, and she's one of the most eminent surgeons in this specialty, and she probably has more specialty work under her cap, so to speak, than most other people. We have Conrad. Conrad doesn't need an introduction. He's now world famous as the man who does 25 push-ups every day. And Rod Jacobs is another speaker. Many of the Indian audience, especially in the subcontinent, are going to get familiar with, as he has a number of talks and appearances in the coming weeks. And of course, Charlotte, who's had considerable experience in Mike Rosen's center in Cleveland Clinic and is now at Hershey. So the questions are open for the panelists. In case you want to ask anything, please go ahead. I have a couple of questions for Eric, Vedra, or any one of you who wishes to answer. One is, why are we operating on these patients? They are rare, all right, but what exactly are the reasons for operating on these patients? Because obstruction or strangulation seems a little unlikely in these cases, given that they are wide and there's no narrow neck, etc. So let's start with that.
You want me to start, Ramana?
Yeah, go ahead.
Number one presenting symptom here is pain. You know, we know that flank hernias, for whatever reason, you know, present with pain more often. And you're right, true flank hernias, you know, don't get incarcerated or strangulated very often, but they do hurt a lot more. And these patients definitely present with pain. Now, some of that is because every time content comes out, it's displacing their ribs. And so they're getting chest wall motion every time they cough or breathe or increase their intra-abdominal pressure. That can also lead to a failure of their rib fractures to heal. So we've had some people with failed bony healing of the ribs. Those are my main concerns. I showed one slide there from Vedra's series where there was some colon sneaking up into the pleural cavity around the edge. You know, that particular portion had a very tight neck, and I'd be concerned about that in particular strangulating. So I think that those are the reason, for me, pain is the number one presenting symptom and the number one reason for pain. I've also noticed, and again, you know, again, a lot of this is just anecdotal stuff. These things enlarge very rapidly. I've seen patients, you know, pre-op, done their workup, seen them back, you know, within 2 months of when I first met them. And these things are much, much bigger over the course of time. And I don't know if that's, you know, Vedra, Rod, or Conrad's experience, but things that I've seen as well. I'm not sure if Charlotte has seen any of these in Cleveland, but again, my experience.
Okay, Vedra, just you know, for interest, are you going to show us anything, or are you just going to talk?
No, I'll just talk. I think Eric did a phenomenal job, as always, presenting this really kind of, you know, topic that's not very common at all. I just, you know, want to tell you a little bit of my story. I mean, Eric gave me way too much credit, but I'll be honest with you, you know, I kind of, first one of these I kind of walked in on, and I didn't even realize that's what it was. And I think most surgeons fix them as flank hernias. And it's only if you dissect really far back that you may actually palpate that, whoa, there is a rib underneath. And that's the first one of these. I was in the OR and then called thoracics in. And basically, you know, they came in and we kind of put the ribs together with some sutures and meshed and everything. And it went fine. But the next one is actually my first post on IHC. Because I actually reviewed the CAT scan, and I would say to all the surgeons, when you see a flank hernia, if you don't usually get CAT scans, I think this is an indication. If you see a flank, because you may find these chest wall defects and diaphragmatic defects that you probably, you know, patient needs to know that they may have a chest tube when they wake up. I think that would be important. So anyway, so the second case, I was actually the next day and I checked on my schedule and I thought, oh gosh, you know, what kind of sutures am I going to use around the ribs? I'm going to use prolines or PDS, or do I actually go through the ribs? You know, I was really concerned about entrapping nerves. So I posted this on IHC, got a lot of different answers very quickly. And then finally, Will Cobb, who's at Greenville, he posted something and he said, you know what, we've already had a bunch of these cases. We have an experience in it that, you know, he's like, you need to plate the ribs because the recurrences that we have had has been because we, you know, used to use pericostal sutures and things like that. So then he sent me an entire PowerPoint basically showing me how to fixate ribs. I got the rep for rib fixation into the room, and it was actually a really kind of fun case, plating the ribs and everything. But his thought was basically, I think if you have a incisional hernia in this space, you may get away with not plating the ribs. I think if you have one of these patients like Eric described with COPD, if they're obese, if they're coughing, the mechanics of their disease process is probably going to force this to happen again. So even if you have, you know, mesh, because to have that kind of force to break ribs and develop this defect, you know, just putting, you know, some mesh and sutures may not take care of it. So I do try to fixate all of these now. And I totally agree with Eric. Pain is the #1 reason. These patients have a lot of pain. I mean, you can imagine with your ribs splitting constantly every time you breathe and move, these patients hurt more than anybody else. So rib fixation, I think, is really important. But sometimes you can't fixate them. The defect is so big. I've been in the OR a couple of times where nothing that you do, you know, because the ribs have broken in the back, and you may have to re-break them to actually put them together. But is that worth it? Actually, one of the last cases, I actually resected the rib. It was a little piece of hanging 11th rib. I mean, it's hanging anyway, but it was so spread that it was actually like hitting the patient's like pubis almost to his ACIS. So I basically just cut that rib off. I called thoracics. They basically don't do a lot of these, and they said, oh, put some mesh, you know. And I said, but he's really hurting, you know. If I leave this rib just hanging so much, you know, and I can't put it together, I just resected it as far back as I could, and, you know, he's done great so far. So anyway, I think lots of good points. We don't have any long-term data, you know, we don't have a lot of these, but we do need to develop some kind of awareness and some kind of a system of handling these hernias, because they're really, it's hard when they come back.
Okay. So do you have any specific indications for fixing the ribs or wiring them, or you do it routinely in every case?
I think, you know, if there are ribs that should be fixed, you know, obviously, like, I think if there's a wide enough defect and you can pull them together, I would fixate them. I think the intercostal muscles, as you guys know, just really don't have much strength to them. They're very thin, and, you know, there's really not a fascial layer that, you know, is strong like the posterior rectus sheath or the anterior rectus sheath. So what I'm afraid of here is that, you know, the force of that hernia, that, you know, it may happen again. So I would, if you can, I would plate them, but that's just because I don't want to have to reoperate on these patients again. You know, we need bigger series to really know if you need to do this or not.
One more question for both you and Eric. Have you actually done some functional studies in terms of both core strength as well as respiratory reserves and the maximal respiratory capacities and vital capacity and all that pre and post-op?
No, I haven't, but I'll tell you, I mean, these patients, they after plating their ribs and doing what just looks like an extremely painful surgery, they already the next day feel better. I mean, they're like, no, I'm not having the pain that I had before. This is a different type of pain, you know, incisional pain. So just seeing that makes me think that they are gonna probably do better long-term. But yeah, you're right, Ramana, we need those studies for everything, not just thoracoabdominal ones.
Okay. Eric?
Exactly the same. I have not specifically studied it. To be honest, Ramana, I don't know that anybody has come to me with preoperative PFTs that I could even compare to, because again, most of them don't have respiratory insufficiency as a result of this. They, you know, if they have PFTs, it's because they may have underlying COPD or something like that. I 100% agree as well. The pain that these folks have post-op, they are almost automatically improved by having additional chest wall stability and coverage of the defect. It's post-operative surgical pain, but they all feel substantially better.
Okay. Sharad, during your time in Cleveland Clinic, have you had experience with these?
Yeah, just because we have a very busy vascular department that tends to still do a lot of open, my experience has all been actually incisional ones. And I think like the biggest thing that I learned from fellowship is that when patients don't have, a lot of times when they have an incisional hernia, they have a significant denervation injury as well, because all of those were cut when they made the incision. So, you know, there's definitely a subgroup of people that come with a bulge. And unfortunately, I think fixing these hernias will still leave them with a significant bulge because the nerves are cut. So certainly you can make things a little bit better, but we will probably quote them a rate of like a 60 to 70% improvement. So by no means when they have the surgery will they be, you know, their contour on both sides of their abdomen, will it be the same. The other thing that I will say that we've done a little bit different than Dr. Pauli's series is we often do a TAR on these situations in these patients. And I think, you know, a little bit of that is because the anatomy can be very complex with all of these different layers of muscle that are, you know, involved or not involved in different layers. By doing a TAR, it kind of allows us to get a little bit more into a plane that we're comfortable and kind of connect from an area that is normal anatomy and kind of work backwards. I don't think these patients necessarily need a TAR, but it allows you to start in a situation where you're comfortable and then kind of work back to abnormal anatomy, just to make sure that you're not injuring anything or causing more defects.
You mean to say you're going through the flank incision, doing a reverse TAR, and
yeah,
developing that plane and going proximal, cephalad.
Mm-hmm.
Okay. And what about tying the ribs or plating them?
We don't actually at all.
Okay. Okay, so that's also interesting. Doing a reverse TAR and getting more space, I guess it makes it easier to get into the right planes, but seems that you're opening up a huge plane anteriorly.
Yeah, and we like, I would say that I think I did like 3 during fellowship. I mean, we always, fairly routinely put in like a 50 by 50 piece of, so we're using it like, we are definitely going into the extreme. The other thing is the people that we're operating on tend to have like, a lot of them have an abdominal component, which is why we need to do the TAR, mostly because they're huge thoracoabdominal incisions. And so that kind of is the reason why we will, maybe like do the TAR a little bit more frequently than most people would. But we also, because they have a big incision and we use like the full length of their incision, we want to cover the whole thing with mesh. So, that's why.
Okay. So, Conrad, comments?
Yeah, you know what? I'm still mind blown by Eric's education on CT scans on these thoracolumbar defects. I'm no expert in this field. I have an N of 1, and I posted on the IHC. And when I posted, just like what Eric said, I thought it was a flank lumbar hernia. But I knew something looked funny about the rib cage as well as the diaphragm component, and I didn't really want to think about it too much or it would stress me out in that pre-op period. When I did my case, I did it robotically, and I honestly had no idea what I was going to expect to see. Going in, I did a pre-peritoneal approach, and it was clear that everything looked funny and distorted and the diaphragm was displaced, but I still didn't know what I was going to encounter going forward. But in that intraperitoneal view that I was in and seeing the right hemithorax communicate with the abdominal cavity was certainly something that I've never seen before. I remember I was doing a case observation at the time, and I was literally asking these dudes, so how am I going to fix this? Knowing the CT, and again, Eric, I mean, I'm still mind blown about how much detail that you were able to explain, reviewing those CT scans of thoracolumbar defects, for sure.
One question. Do these defects on the thoracic wall and interface with the diaphragm and the upper part of the flank muscles, the obliques? Is there, in specific cases, a situation you think we could just take big transfacials through everything and just bring them all together and then put a mesh? Do you think that happening?
Yeah, so with me, because there's associated denervation, there's a wide defect. With all significant off midline defects, I use heavyweight mesh. I try to primarily close everything. I think the mesh gives a bit of support to that lateral abdominal wall. Yeah, again, my experience is not that much with this, but I do a lot of flank hernias. I probably do 2 or 3 flank hernias a month, at least before I change practices. I think they do need extra support there for sure.
Eric?
I think that the biggest advantage of doing these repairs is that just like a paramedian incision has a lower hernia rate because you have the ability to close 2 myofascial planes, right? In this particular case, you're closing in multiple layers. I mean, if you think about the repair that I kind of described and that Vedra described, you've got a peritoneum that's closed, you've got mesh in a sublay space, you've got intercostals that are potentially closed, internal oblique and transversus are closed, and then external oblique is closed over the top. So you've got the ability to put things back together layer by layer. And I think a multiple layered closure is part of, you know, one of the strengths of doing a repair that is not, as you described, sort of an en masse, you know, closure of these things.
That's right. That's right. That sounds.
Charlotte, can I ask you?
Go ahead.
Charlotte, can I ask you? Yeah, Charlotte, can I ask you where those incisional hernias? They're from thoracoabdominal incisions for your vascular team. Is that correct? And is it a frequent occurrence?
Yeah, they still do a significant
an esophagogastric surgeon, and that's why I gave up doing that, because it's a crappy incision, and they get a lot of pain and.
Yeah, a lot of the, so we work with the vascular department to kind of have a registry of the patients that they do the open thoracoabdominal aneurysm repairs on, so we can kind of follow them to see what they're, like, if they develop hernia. So those are the one group of patients. And then the other group of patients is some of the large retroperitoneal, whether it's like a kidney or a sarcoma. Those are the other, and we actually tend to use the incision that they have. But yeah, it's not a great one.
Okay. So
I'm
do you have anything
like
else?
Conrad, I have
say, go ahead.
pretty limited experience. Yeah, I was just going to say I'm a bit like Conrad. I have pretty limited experience. Many years ago, I helped repair one where simply cobbling the ribs together and whacking a big bit of Marlex mesh over the hole in the diaphragm from the thoracic side. And the other ones I've done have been sort of an onlay through thoracoabdominal incision on the patient's left, and pretty poor efforts. And the last one where I actually think I had some expertise to do something, the patient was morbidly obese and a smoker and COPD, and it was one of those spontaneous ruptures, and she never came back to have anything done. So I don't have much experience, but I've learned a lot tonight. Thank you, Eric and Vedra.
Okay. I have one question for Vedra and Conrad. Given the small numbers, of course, that's a disclaimer everyone has to issue. The recurrences in your series have been from onlay repairs. Would this be a good example for the anti-onlay zealot?
So, I mean, the recurrences in that series were because those were not plated. So that's, you know, full disclosure, the patients that we contributed, you know, were after Dr. Cobb very kindly alerted me to the high recurrence rate if you don't plate the ribs. You know, I think it's possible that you can get away with this, you know, and not plate the ribs. It's very uncommon. Patients move around to different centers. You know, I just recently saw somebody who's had 2 of these repairs just with mesh placement. One was actually done minimally invasive. The other one is an onlay. You know, to me, it seems, and, you know, everybody brought up the point very nicely of the innervation. You know, just when you bring the ribs and you wire them together, there's no way that the chest wall is not going to look symmetric. I mean, there's no inner space, basically. Plus, you have the mesh underneath, you know, which is extending onto the abdominal defect and up onto the diaphragm. So, I mean, it is a little bit more work, but I think you do get the ultimate chest stability there. So I think it should be considered. So yeah, the recurrences only happened when there was no recurrences at all when we plated the ribs.
And then in those cases, you still did a sublay, right? Not an onlay.
We essentially all do either a preperitoneal or retrorectus, but yeah, it's a preperitoneal mesh placement. Yeah.
Okay. So, what happens in your center as far as midline sternotomy dehiscences are concerned? You know, the ones where the wires break and they get infected, they debride and take out the sternum and the wires, and then you see the part of the heart and the lungs are, you know, kind of seen through the skin.
Yeah, I mean, I'll tell you honestly, we don't see a lot of those, and I'm really impressed. I'm not sure, you know, when I was in residency, we saw a lot of those, but our thoracic guys, I don't know why we just don't see a lot of those. I do remember one of Dr. Henford's patients that I think when I was in fellowship we fixed, and the guy was a very nice, he was actually a physician, and his colon was up where his clavicles were. You know, he had completely essentially, and we had to just essentially recreate a diaphragm for him. I mean, quite a big surgery, but the patient did very well. But you know, it's always scary when you're looking at a CAT scan and the transverse colon is at the clavicle level. I think it's a warning sign for sure.
All right. So,
Rama, I don't know how much time we have. Do you want to see a little short video on my intervention? I don't know.
perfect. Please.
I actually just gave this talk recently. Again, this is this is a 45, I think, year old or 55-year-old male who coughed. No previous surgical intervention in this area. Developed a flank bulge. Was repaired by some outside facility, a laparoscopic IPOM technique, that he said he felt no relief in the PACU. He was referred to me approximately a year later after his recurrence. I had him lose weight to prove to me that he would be a willing participant in his recovery. He did lose weight, but he was still obese, I think a BMI of around 41. And I took him into surgery. And again, I honestly did not know while I do a lot of flank hernias, I knew that this was different, but I didn't exactly know what I was going to see. So you can see pretty large thoracolumbar defect. Normally, this is how I did in fellowship. We would do a preperitoneal technique. We'd access the preperitoneal space many times by going through intact muscle. And it seems to me it makes more sense to do that from the inside. So you can see the anatomy of his thoracoabdominal defect here. I saw ribs and I still really didn't know what I was going to expect. That was the IPOM curtain that failed immediately. So my plan was to do preperitoneal pretransversalis dissection off the transversus abdominis muscle. That's pretransversalis off the diaphragm there. That was intact. My goal was to recruit as much peritoneal sac as possible, and that would serve as my autologous covering for the mesh. But I could not tell the extent of the defect until everything was dissected. So that's the cephalad aspect of the transversus abdominis defect, the intercostal hernia component, that's the hernia sac here. I'm going underneath the peritoneal sac. Here, that's diaphragm. And then once I've satisfied enough lateral and posterior overlap, we cut the hernia sac. So I'm using table motion on the robot just to get a peek, and obviously there's lung there. And at that point, I literally almost shit myself. I was like, I don't know what to do about this. I'm asking the case observers watching me at this time what they would do. They said they had no idea. I put more ports just to get a better look. And at this point, I was like, well, you know, just like bringing the rectus back into the midline where they should be, let me reapproximate the diaphragm back to where it should be, which is the chest wall. And I did that in layers utilizing V-lock suture. So this is the cephalad aspect of the diaphragmatic disruption. I'm suturing that back to periosteum of the lungs. Again, no experience with these thoracoabdominal defects. I thought it made sense to wire a pigtail catheter in there. I had my anesthesiologist Valsalva and suction prior to the closure, and then I could focus on the disruption of the TA. So using number 1 V-lock, reapproximating the TA, and getting bites of the overlying intact internal oblique, starting on one side, going from the other, and then primarily closing this defect. I didn't do anything about the intercostal hernias. I remember on the IHC they were recommending that, but I didn't. So just sutured Marlex to the abdominal wall and then closed it. And this is him pre-op and post-op.
Okay, relax, cough, strain.
So I've seen him in a year follow-up, but I've lost him. So this is a great reminder for me to get him back, because I wanted to order a CT scan for him just to see how he's doing. So hopefully I can get him back. I'll post that on the AWR website, and hopefully he hasn't recurred.
Very cool. Sharad?
Yeah, thank you. Thank you, Dr. Conrad. I think that was a wonderful video that you have shown. I would also thank Dr. Eric. I think Eric has left for the day. I would thank the panelists, Dr. Vedra, Dr. Jacobs, and Dr. Charlotte for actively participating. Of course, thanks to Dr. Ramana for a wonderful conduction of the whole seminar. Are there any other questions on the panel, to the panel and the experts? If they are, please go ahead and ask. I think there was a lot of chatter on the chat box. If there are any more comments, please go ahead.
Can I ask a question, please?
Yes, please.
Yeah, this is Dr. Brijesh here. Good evening, everyone. My question is, during the primary surgery for trauma, if there is a large thoracoabdominal defect in the myofascial plane, has anybody put in a mesh in that during primary surgery? And if, how do you manage it?
Rajesh, I think that's a really good question. I think if there's contamination, I would not. But I think if you have a disruption there, it's probably better to reinforce it some way, especially, sutures, things like that. I don't know that in that case scenario, I would actually be plating anything. But as you know, from plating ribs for trauma, otherwise, that's usually not done in an acute setting, but it does improve pulmonary stats. So I think, it's a good question, but definitely if there's no contamination, I think it's something to consider.
Thank you. Thank you very much.
Can I ask one question, please?
Yeah, sure.
Hi, do you have any role of biosynthetic mesh in these kind of scenario of acute trauma, whereas you're expecting some contamination, and is the repair will be better with some biosynthetic meshes, like physics and all?
I'm personally not a huge fan of biosynthetics, to be honest with you, just because we don't have any truly long-term data that supports the use of these, especially in contaminated cases. I think some of the best series still have very high recurrence rates. I think in contaminated kind of spaces, I'm much more comfortable using biologic mesh because we have much, long-term, 5-8 year data on those meshes. But yeah, I think if you can use a synthetic, I would always go for a true synthetic unless if there's a contaminated, some contamination.
Okay.